So what do you know about frozen shoulder? So what's the another name of frozen shoulder? Tell me the name of another name for the
Like
frozen. What, doctor?
adhesive capsulitis.
Yeah, adhesive capsulitis, right? Okay. So here, first of all, so we have two main painful um, shoulders, right? According to the cause, we have frozen shoulder, and other one is rotator cuff tendinopathy or rotator cuff tendon injury, right, doctors? So these two, you have to differentiate these two because these two are always confusing. Okay. Yeah. This is the, I think, yeah, this is the day two questions. They have given for the this case, the patient, not the patient, for Ricola gave this question. So let's discuss about these two things. Okay. Then we will discuss about the questions. So, what is the frozen shoulder? It's an idiopathic or primary frozen shoulder is defined as a condition characteristic by functional restriction of both active and passive shoulder motion, for which radiograph of the um, glenohumeral joint are essential, unremarkable except for the possible presence of osteopenia or calcified tendonitis. You don't have to remember everything, just remember it's a functional restriction of the both active and passive movements, right? So always remember in adhesive capsulitis or frozen shoulder, there is both active and passive movements are involved. Is a one of main important point for these two topics. Okay, so remember. Then okay. So what is the history of this frozen shoulder pain? The pain is idiopathic. Frozen shoulder is insidious and there's no history of trauma. Location: frozen shoulder pain is classically perceived around the region of deltoid insertion. Right, deltoid muscle, especially the insertion area, can be feel the pain. Duration: the pain associated with frozen shoulder is persistent and may be chronic. Character: is the pain associated with frozen shoulder is more often dull and aching pain. Aggravating and relieving factors are aggravating and relieving factors. Pain is often worse at the night and with extreme of movement. And NSAID drugs are often ineffective. Here, so NSAID are not very effective, right? So in night time, the pain is worse, right? Pain is worse. Then radiation. Pain may radiate down the arm but rarely passes beyond the elbow. Usually till elbow, pain can radiate, right? Timing. Pain is variable depending on the phase. Throughout, it may persist longer than 4 years. Severity: pain is often severe in phase one and varies throughout the phase, progressively decreasing, right? When it is becoming chronic, the pain also can be little bit decreasing, right? Okay, so here. And three phases for this adhesive capsulitis. So phase one, this is the very painful phase, or this is the actually painful phase. And we call it pain prominent phase. Here it lasts longer, 2 to 9 months. 2 to 9 months it lasts long in, and progressive stiffness and increase in pain on movements at the night. No history of shoulder trauma. Right? So phase two, a stiffness freezing or stiffness predominance phase. So first one is pain predominant phase and the next one is stiffness predominant phase. Just give me 1 minute, doctor. I have to charge it. Yeah. The second phase is stiffness prominent phase. It usually lasts in 4 to 12 months. Here, the gradual reduction of the pain, but stiffness can persist with considerable restriction in range of motion, especially active and passive both. Remember, I am repeating these words because they are exactly given in the question in STEM. You have to differentiate those from the rotator cuff tendinopathy. Okay, because of that, I'm repeating these words. Active and passive movements are restricted. Then pain may be apparent only at the extreme of movement. So gross reduction of glenohumeral movements with near total obliteration of external rotation. Then phase 3, resolution or thawing phase, is last for 12 to 42 months. Variable improvement in range of motion with a resolution of the stiffness, right? These are the three phases. Please remember, phase 1 is pain predominant phase, the phase 2 is stiffness predominant phase, and phase 3 is recovering phase, right? Yeah. So, yeah, I'll quickly explain these things. No need to read everything here. Yeah, okay. Okay, adhesive capsulitis, frozen shoulder. So onset, it's a gradual and progressive, right? We all know, like it's a chronic disease, right? Even painful. It's like here, it's a gradual one. Yeah, when we discuss about the phases, it's also like monthly, appear like 2 to 9 months, then 4 to 12 months, right? It's a gradually occurring disease. Then pain is diffuse shoulder pain, is a dull pain, often worse at night. Active range of movement decreased and passive range of movement also decreased. Both are decreased in here. Then abduction markedly restricted in here. Then exertional rotation early and severely restricted. Strength normal but limit by stiffness, right? Then special test, we have global restriction and no impingement pattern, but they are not asking from these tests. Okay, global restriction, these tests they are not asking, but you have to just remember it. Okay, yeah. So then let's discuss about the management. So management. So what is the usually conservative management? What are the principles we have? First of all, we have to educate the patient about the nature of condition, nature of history, and potential chronicity of the condition. And regular and breakthrough analgesia, because there's a pain, right? We have to give analgesia. Start with simple regular analgesia and here analgesia, then supplemented with a stronger breakthrough analgesia, and topical creams, lotions, ointment are ineffective, but they may be used for the reasonable if the patient perceive that there is a benefit and no harm being done, right? So physiotherapy, this is the another most important part. It's involved early and intervention strategies will vary depending on the phase, right? Intra-articular corticosteroid. Next step is intra-articular corticosteroid. These are the more effective if it start earlier in this stage, right? So aseptic technique is necessary. Accuracy can be ensured using anatomical landmark or imaging guidance, right? Because they are intra-articular corticosteroid, right? So always we have to make sure about the aseptic, right? It should be aseptic because if there's any contamination present, there can be septic arthritis, right, in the joint. So we have to always take precautions to prevent septic arthritis. Then we have like, okay, We have tried analgesia, physiotherapy. Both are not working. Then we can go with intraarticular corticosteroid injection. It's also not working. Then we have the last option, other injection therapies. So we go, the main one they are asking is hydrodilation. This question they have asked in June. What is the last option? So last option is hydrodilation, and they have given in the exam the answers as physiotherapy, intraarticular injections, and say then do nothing. And as I remember, the next one is this one hydrodilation. So answer is hydrodilation, and other four answers was there. If you have the files and everything, you can go and check it. Okay, because these are repeated cases, repeated questions. Like if you are doing February course, we are currently doing February course, and so many questions are recalled, especially from November. There are so many repeated questions, doctor, like exact same question. So because of that, please take serious about the recalls, right? Because it's a very important, right? Very, very important. Okay, so remember about this hydrodilation. So what is hydrodilation? Sorry, dilatation. Hydrodilation has been shown effective when used along or combined with the physiotherapy. It's an injection method, right? Yeah. So just remember about the name. So yeah. Okay, that's for what? That's for adhesive capsulitis. So tell me, what are the main features that you should remember in adhesive capsulitis? Quickly tell me. Like you have to actively participate, doctors. Otherwise, it's like very boring, right? Okay, I'm asking these features because in the exam there's no one here, only you and your brain, right? In your mindset. So, like if you are practice those points, like if you are doing recalls and you're practicing these things, like these key features, then you will remember it, right? Like you don't have time to think, you just have to just like when you read in the question, oh, this is from adhesive capsulitis, okay, active and passive movements also restricted, so it's not the rotator cuff injury. Then okay, it has three phases, and this one is which phase? Okay, they have already tried analgesia physiotherapy, and they're asking what is next step, like that in your mind. Like there is a story, right? Like once you are reading the question in your mind, everything should be worked like that very quickly, because you only get like 1 minute for each question, and some questions you need more time. Like these questions you can save your energy, like sorry, you can save your time, because some medicine questions and some surgery questions and some ops question, you have to think, right? You know the concept, but you have to think, you have to compare, right? They are giving some hemodynamic unstable situations, and you have to think and you have to answer. So if you these are like easy points, right? If you know the key symptoms and key points, then you can save time for those harder questions, those questions who need like more thinking, right? Yeah, that's what I'm telling. So revision, and so if you are revising these things, it will eventually comes into your mind. Okay, yeah, that's what I'm telling. Okay, no history of trauma, passive and active movement affected. Mm-hmm. Okay, so let's discuss about rotator cuff injury or rotator cuff tendinopathy. Then we can compare those two, right? So, what is rotator cuff tendinopathy? So, how rotator cuff is made by? So what are the rotator cuff muscles? Tell me what are the rotator cuff muscles, doctors? What are the rotator cuff muscles? We have supraspinatus, we have infraspinatus, and we have teres minor. So these are the rotator cuff muscles, right? Rotator cuff muscles. Rotator cuff muscles. Supraspinatus, infraspinatus, and teres minor. Okay, remember those things. Yeah, D2 February. Yeah. So usually, if there is a rotator cuff tendinopathy or injury, usually it affects the main muscle among these three. So, what is the main muscle that can affect of affect from these other rotate from these three rotator cuff muscles? So, what is the main muscle that affect? Tell me, doctors. These are very high yield topics. You should know, like you don't have time to think about it.
Supraspinatus.
What about other doctors? It's a supraspinal, especially this situation, this rotator cuff injury is happen when but there's a tear in supraspinatus muscles, right? Supraspinatus muscle is the main muscle that contribute, right? Supraspinatus, right? So good. Here, then let's discuss about how this pain is characteristic. So, gradual onset shoulder pain, lateral shoulder pain may radiate to the mid-arm and worse with overhead activity. In the questions, they are usually given like the patient is doing some overhead activities like that. Okay. In questions, you can see repetitive overhead activities like in the history. Okay, like that. As example, what are the overhead activities? Reach in, comb in hair, hang in clothes, right? Then painful arc during the abduction. Painful arc during the abduction, typically 6 to 120-degree arc is very painful. It's a very painful arc, doctor. Yeah. So night pain, especially lying on affected side. So this feature, the night pain, can be seen in both scenario, right? Adhesive capsulitis and rotator cuff tendinopathy. Both scenario you can see this night pain. Okay, those are the similar features. Then risk factors, repetitive overhead work or sport, age more than 40 years and previous shoulder overuse. Yeah, previous shoulder will usually affect older than 40 years old. Then examination findings. So inspections usually normal, no deformity, and active movement is restricted. So active movement is restricted. Painful arc between 60 to 120 degree abduction. Pain with resistant abduction or external rotation usually during the active movements restricted, but in passive movements there's no restrictions, right? And we have some special tests, and usually in the exam they are asking about these what empty can test. So what is empty can test, doctors? So what is empty can test? Okay, so what we are doing here, we advise patient to both the arms of the patient are raised to the 90 degree in the scapular plane. Here 90 degree in here 90 degree to scapular plane. Then the arms are then fully internally rotated. Here the arms are internally rotated to that the thumbs point toward the floor as the patient were draining liquid out of a can, right? That's why we call it, this is an empty can test. That's why we call can test, right? So like that here, thumbs are down, these hands are internally rotated, and this hand is in 90 degree to a scapular plane, right? So then next what we should do, the examiner then apply downward direction face to the arm. So examiners try to make the apply a force to downward, right? To downward, then patient is instructed to resist this force. So this is the empty can test. So then what happen if empty can is positive? So what we can see if empty can is positive? Tell me, doctors. Empty can positive mean what? What we can see in empty can positive? What patient can
Supraspinous
feel?
muscle involvement.
Yeah, we know is supraspinatus involvement. Now I'm asking if it is positive, what patient can feel? Okay, after the doctor is, but this doctor is applying a downward pressure, a downward force. Then what can patient feel? These patients feel pain or weakness during this resistance, right? Because he's trying to resist this force, because doctor is applying a force and patient is advised to do the resistance, right? Because of this process, the patient can feel pain or weakness. Then we call this empty can test is positive, right? So, because if the patient can feel pain or weakness after this test, during this test, we can identify there is a injury or tear in the supraspinatus muscle, right? Hope you understand it, right? Here, power mild weakness due to the pain, true weakness suggests rotator cuff tear, right? So, passive movements usually in full range in this patient, so it's not restricted. I hope you understand it. Okay, and here also treatment. So initial treatment. First one is modify activities, medications, exercises like pain management, like that. If it is not working, we have to go with steroid injection. Then the last option is surgery, like that. Okay. So yeah, here also the same. I'm just very quickly discuss it about. So and one more thing. And there's a one more thing you should remember. Okay, in adhesive capsulitis, these patient have specific relation to one disease. What is that? What is that, doctors? They're strongly associated with diabetic patients. The rotator cuff, so not rotator cuff, adhesive capsulitis. They are mainly associated with diabetic patients. So please remember these points as well, because in the STEM they can mention it. Okay? Yeah. So let's discuss some questions. A 63-year-old woman present to the GP with 4 months worsening right shoulder pain, especially at night. She has found it more difficult to hang the laundry and with changing clothes. Okay, so it's a overhead movement here also, like not over, yeah, kind of he's tried to hang the laundry and change in clothes. She remembers injuring her shoulder about 5 months ago when she had knocked it on the kitchen shelf, after which she had some trouble reaching above her hand. After about a month, this began to worsen and has continued ever since. A medical condition include type 2 diabetes and hypothyroidism. On examination, she has restricted range of active and passive external and internal rotation, but normal power movements are also painful. Near test is negative. So, which one of the following is most likely to diagnosis? Okay, so now tell me what are the key features that we can take from this stem? What are the key features you can take from this stem? Tell me, doctors, because those are the things should be in your mind before your exam. Okay, progressive pain, active and passive movements, movements, restriction, right? Inability to hang your laundry. Yes, good. Okay. Yeah. Here, presentation of adhesive capsulitis freezing phase, which can last up to 9 months. The hallmark of physical examination in reduce active and passive range of motion. This is usually followed by the frozen phase, comparing improving pain with residual stiffness and subsequent by the thawing phase or recovery phases, gradual increase in range of movement. Both these phases are variable and can last for months. Risk factors include diabetes, hypothyroidism, and injury that prolong immobilization. Right? Okay, next one. 72-year-old man presented to the GP clinic with 3 months history of left shoulder pain and stiffness. The pain is worse at the night. All shoulder movements are restricted. He is right-handed and can no longer play balls due to these symptoms. There's no history of trauma. He does not have any pain in the any other joint. Medical history include type 2 diabetes and hypertension. Medications including metformin and amlodipine. He does not smoke, drink or alcohol occasionally. On examination appears well with vital signs with normal limits. There are marked reduction of both active and passive range of movement in the left shoulder. The empty can test is negative. Which one of the following is most strongly suggest associated with this patient's probable diagnosis? Not about other doctors. You have to quickly answer. Yeah, here. The patients present with the features typically of adhesive capsulitis, frozen shoulder, is characteristic by gradual onset shoulder pain and stiffness affecting both active and passive range of motion. The negative empty can test help to rule out the rotator cuff pathology. History of diabetic mellitus has the strongest associated with the adhesive capsulitis, with up to 20% of diabetic patients experiencing episodes during their lifetime. The exact mechanism is not fully understood, but may related to glycosylation of the collagen in the joint capsule. Now you can see the points, right? Now you know the points. I gathered all points from the e-medicine specifically when I was preparing. Yeah. That's why it's very easy for me to revise and give me, because I also did my exam in last year and I remember most of the cases. Okay. So next one, a 44-year-old man presented to the GP with 1 week history of right shoulder pain. He reports that the pain is reproduced during the game of rugby when he lifts both hands overhead to catch the ball. This sharp pain tended towards the repetition of the overhead activity and lasts for 6 hours after the game. He usually takes ibuprofen to relieve the pain, and but now the patient persists throughout the night, and he finds difficulty sleeping on his right side. On examination, he appears well with vital signs within normal limits. A short examination review a positive empty can test. The examination diagnosed patients with rotator cuff injury. Which muscles is associated? Okay, yeah, here you all know the answer, right? Yeah. Yes, supraspinatus muscle. I'm not gonna read it again. Okay. Okay, this is 64-year-old man present to the GP practice clinic with ongoing shoulder pain and reduced function for 4 months after sustaining rotator cuff tear while playing football. The diagnosis was confirmed with an ultrasound showing the partial thickness tear. He has no significant medical history and take no regular medications. He works full time as architecture and remain fully independent with activities of daily living. He has a complete course of physiotherapy but continue to have symptoms. On examination, he appears well with vital signs within normal limits. There's a reduced range of movement in the left shoulder consistent with rotator cuff tear. This is another point you should remember for rotator cuff um, injury. So I'm gonna stop the screen sharing and I'm gonna tell the answers and you have to select one because it's already marked in here. I need answers from you. This is a good point. Here, which one of the following is most appropriate time frame for surgical referral if symptoms persistent despite conservative management? After 6 weeks of conservative management, after 6 months of conservative management, immediate referral after 12 months of conservative management. So, what do you think? After 6 months, after 12 months, after 6 months of conservative management or immediate referral? What do you think, doctors? What you can tell about this? What about other doctors? Why immediate, doctor? Why? Why immediate? Why immediate? And there's a just partial thickness tear, right? Partial thickness tear. Okay, I'll show the answer. Okay, I'll show the answer. The answer is after 6 months of conservative management. So please remember here, the case is patient present with partial thickness of rotator cuff tear, partial thickness rotator cuff tear, ongoing symptoms despite initial conservative management. The timing of surgical referral depending on the several factors including age, mechanism of injury, tear size, and response to the conservative treatment. After 6 months of conservative treatment is the most appropriate time frame for surgical referral if the symptoms persist. This allows adequate time to assess the response to non-operative treatment while not delaying unnecessarily if surgery is ultimately needed. Conservative management should include physiotherapy, activity modification, and appropriate pain management, right? So immediate referral would be appropriate for acute traumatic full thickness tear in younger patient or in case with significant weakness or functional impairment, this patient's partial thickness tear does not meet these criteria, right? So decision for the surgery should based on the factors including age, including persistent pain, functional limitation, failure of conservative management and patients, factors of like such as age, like that. Yeah, okay. So hope you understand it. Yeah, that's all for the questions as well. So that's all for these two shoulder pathologies. Okay, do you have any questions? Just stop.